All right, so my name is Dawn Miller. I'm the Supported Employment Program Manager for the east side of the state. Have been since the FCS program started. So looking forward to talking to everybody today. I'm going to pass it off to either Darren or Anessa to introduce themselves.
I can go next. Hi, my name is Anessa Williams. I am the Housing Subsidies Administrator at HCA and also the Supportive Housing Program Manager. Darren, go ahead.
Overachiever. Overachiever.
You go, girl. Hi, everybody. My name is Darren Paskey, the Supportive Employment Program Manager for Western Washington. Thanks, everyone, for joining us today for documentation training. I'll hand it back to you, Don.
Well, and so next slide, I think. All right. I tend not to read slides to folks. I'm pretty sure you can do that on your own. But one of the things I wanted you to notice is where it says resource sites, that pathways to employment and pathways to housing are active links. The ipsworks.org is not an active link, but when you get the recording and the information, you'll be able to use those active links. We are going to go over some actual documents. So one of the ways I've had people ask, how does this differ from Golden Thread training? Part of it includes some Golden Thread, but as you can see, a fairly good chunk of it is related to specific documents that we hope you're using. Some of them you're mandated to use, like the treatment plan and progress notes. You can't provide a Medicaid service without having a treatment plan or whatever you call it and progress notes. So we'll actually be going over some of those documents. We'll be delving a little bit into, we have a Medicaid documentation guide, and the documentation manual. We'll be going through that to some degree. And so there's your previews of coming attractions. Darren or Anessa, do you want to take the next slide?
Sure. Definitely, when we're thinking about FCS supported employment, we want to kind of really focus on social determinants of health, and requirement for billing is also worked through the online portal at the WellPoint site. So I really encourage everybody to have that provider manual on their desktop so you can really look at the pre-employment, post-employment, pre-housing, post-housing, different billable services, so we can really craft some of the notes so they're really intentional for the services that we're having. I can't remember, are we going to take a peek at the portal online to switch screens, Dawn and Anessa?
Let's ask folks. So this portal is the assessment form for people that are being referred to WellPoint for either supported employment or supportive housing services. Does anybody feel like we need to move over to that and take a look at it today? Or is that something that you can do on your own? I see yes, please. So yes, that sounds like something that the group wants to do.
All right.
Vanessa, my computer's not behaving well. I don't know if Darren, it looks like you're pulling it up. Thanks for that. But if it becomes cumbersome, maybe Anessa can pull up some of the other stuff.
Sure. So I'm just at the WellPoint site. I'm going to scroll down. My apologies. I'll kind of go slow because it kind of makes me nauseous if I go too fast. And coming down here to this section for assessments. And Ness and I just did a training, I think last week, and we kind of found out there are some different elements between the employment and housing side. So I'll go ahead and jump into the assessment piece. And you'll see these fields come up. And just for, this demonstration, I use my favorite person test. If I could spell right.
Very testy person.
Very testy today. So definitely the system knows birth dates. So we have to go back in time and make sure we're 16 and above. And sometimes Darren has a problem with this. So I'm going to try to go back in time to make sure we hit the sweet spot there. There we go. Um, and this is another important date. Is the date that you're completing the assessment? This will have implications because this is that start date for the actual assessment. When you get the authorization, this would be that start date. And we'll just count that as today. So the next thing that comes up, if this person is experiencing homeless or not, if we go yes, then it's going to require an address to put in for that specific area, geographical area that that person might be experiencing homelessness. And I'm just saying that's me, the case manager. This is also really critical. If you don't have a verified provider one number for the individual you're serving, your authorization will not go through. So I really encourage people to be familiar with provider one, to go into the system and verify that their Medicaid is current. Otherwise, this authorization would be denied. Don't take notes on this number because it's just a fictitious provider one number that I'm using just for this example. And we'll just say they're a Marine. This next step is where we're really looking into some of the specifics, those health-related needs that we're going to help somebody with to navigate on the employment side. So as you can see, there's some multiple options. We only need one for this. And my history is I've worked with a lot of people with behavioral health issues, kind of really struggling with that stabilization because without services like we're going to provide, they might have some more episodic negative symptoms that are really going to be able to impact their ability, to change from their current functioning role into that role of employment or education. And a lot of folks I've worked with are dually diagnosed, so I'm just going to do two. You don't need that, but in this case, those are some of the experiences I've met working with people in the field. And then again, we just need one risk factor. And I talked about, we have at risk of deterioration. Things could get worse if they're not in our programs providing these services. Or maybe we're having somebody that's having a hard time staying in that role of performance. I've worked with people who are really good at getting a job, but they lose it 30 to 45 days over and we're repeating that cycle. Or maybe they're having a hard time in school maintaining that workload or just showing up for attendance. So there might be some substance use history that the person is challenged with. Or just that inability to maintain employment. Maybe it's because of a traumatic brain injury for that. Or maybe they just have a hard time staying employed. So there's a lot of flexibility. My belief without these critical services of FCS, they're going to be at risk of deterioration. So again, you only need one, and definitely through all these different things, this kind of encapsulates a lot of the issues that are going on behind the scenes working with people in support of employment. And you can also add some additional information here. Maybe because this person was in the military, they have some PTSD. It's not required to put anything in this field, but for me, if there's an open dialogue box that I can reinforce some of the barriers, I'm going to add that. Granted, this might just be the person sharing this information during the assessment, and then WellPoint may ask for additional paperwork or documentation, but we can just use that person's self-report on some of the barriers coming up. And this is also critical, if they're coming in through FCS SE, we're going to say, sure, they are looking for work. And all we do is have to use the person's voice to move the process ahead. And we're just going to say right now, the person's unemployed. And our person struggled, they're going to be on Social Security income is very limited. But as you can see, they could be in any one of these different areas for income source. And then housing type, we said the person's, homeless. So we're just going to go follow up with that, not housed. And then for not housed, we have these other examples, to use. So we'll just say maybe he's living in his car right now. And this is, again, kind of really looking at an employment assess to kind of assess where the person is. And maybe they report, well, I've had poor work history. And maybe I don't have a lot of pre-vocational skills. I would really love to have a resume to really highlight my skills and ability. And boy, I sure could use some support because when I start a job, it's really hard for me to keep that job. And again, we can just use this is just the person's self-statement to obtain information, or we could add other if you have some other documentation that somebody may have come in during the intake for your agency. Unfortunately, there's no dialogue box here to add additional strengths, but they're here, they're talking about employment, so we're going to say there's some motivation. Maybe the person's pretty flexible. I just need a survival job right now. And maybe let's see, some good interpersonal skills that the person has. And maybe in the military, they did some educational attainment and some certification. So we can kind of look at some of these highlights to really reinforce some of the great things that the person's already done, and that could be transferable looking to employment. And now we have some of the barriers, maybe there's some ongoing stuff, sobriety and abstinence, whatever those issues are, have been really a challenge. Maybe they lack some, own transportation. Maybe here there's some, court requirements that the person has to be responsible for that might impact potential job search strategies or, a time of day that somebody can be looking for work or working. I know sometimes, especially if people are homeless, they don't have a lot of documentation. But we said they were on Social Security, so we could probably get proof, some of those documentations. Maybe there's a Social Security card. Some of this other stuff might be very hard to get. And in this case, we don't really have any other supporting documentation. Excuse me. And again, if there's some circumstances or something here, we can add that in the dialog box. So this is an important piece. This is just you filling this out, with your credentials and your agency name. If applicable, you could fill out some supervisor information that's available. This is really important that the person is consenting to services. And this is like the last page that you can go to before you have to review and submit the information. And that's the only time you're allowed to print this. So I really encourage people, after you put this identification information here, that you make a note to print out the document because we want to capture a wet signature for the people enrolling so you can put that into your documentation files. And it's a great way to do that if you could print it out in a hard form or download it into a PDF and then print out that page just so you have that wet signature in the file to really verify that you're working with the person together to create this assessment for folks. I don't know, was there anything in the chat, Dawn or Anessa?
Oh, we're all good.
Okay,
Yep,
awesome.
no recent stuff. So if anybody does have questions about this, please feel free to either unmute or put them in the chat.
So we'll
Yeah,
just
I have a question.
sure.
Yeah, so for like an audit, would sorry, I'm new to all this. It's only been a year for me, but for an audit, would they be looking for a wet signature on this assessment?
They would be looking for that. So in your documentation, you would have that note saying, I met with Darren, we completed the form. That will be the clinical documentation that supports this. And you should also have this document in your chart just to verify that you've done it with the wet signature. That would be the highest level of fidelity for if you were in an audit situation to show that I have the form, this is what we talked about, and here's the signature.
Okay, so you want the wet signature for an audit.
Well, for any just daily operations, but if you were in a review and you didn't have that, that could be problematic for administration. That
Hmm.
did you really meet with the person and get the signature? We want to have that closed loop that we're working with the person, we're addressing some of the social determinants of health needs. And yeah, we have the signature and the timestamp. This is when we worked on it together. It just really makes it a strong case that you work together with the person to come up with the next steps for the goals.
Okay. And then my second question is so like let's say you meet with somebody, they've been authorized and they do their 120 units, and then you lose contact with them and now they're ready to re-engage. Is that gonna be at what point is for in time, is it a reauthorization or another initial authorization? What
That's
is
a really
the
great
gap?
question. So thank you, Chloe, for being new at this and asking these questions. So once you do this form, and we'll say we did such a good job on this together that we get an authorization in 7 days. And so that would be for that 6 month period. And things are going really well. Maybe things are going so well, somebody gets a job. And then they say, hey, Chloe, thank you very much. I'm kind of done. This is my job. I don't need any more help anymore. And right before the end of the authorization ends, WellPoint will reach out to you, say, hey, do you want to do a continue authorization just to kind of have that authorized benefits? And it's really hard because maybe somebody's not connecting with you. And with evidence-based practice that we have, we really focus on assertive engagement, that we're not just passively waiting for somebody to come in to see us, but we're doing things to go out in the community, maybe checking in with the job site, different things. What strategies are we doing to try to make that connection? Maybe we're even going with a coworker to the person's home or something, or trying to meet them somewhere. What kind of things are you doing to, have those connections to, ask for that reauthorization? But there are times where people do, separate from services, that authorization would end, and maybe they come back in 3 months. Then yeah, you would have to do you would have to do a new authorization. So it's really critical to track units that you're doing and have that conversation with people that you're engaging to continue that long-term relationship that you're building, so that when things change, they still have those supports that you're providing through FCS. Is that helpful?
Well, and I will say for the newer folks, there are reauthorizations, and then once a person's receiving services, there's reauthorizations, which means you've come to the end of your 6 month period, and need to do another authorization because they still have a need for the services. So all of your documentation needs to show that the person still requires the service, and that's why you're reauthorizing. But there's also exceptions to the rule. If somebody is requiring a whole lot of assistance in their 6 month period and they've blown through the units that they've got, you can request an exception to the rule, which means asking for more units within that same 6 month period, that you're not even done with the 6 months yet, but you need more units in order to continue working with the person. I do see Chantel. Danielle had said, do we need to send an attestation of homelessness every time reauth, or only the initial one? And Anessa had said only initial. I see that Chantel says, who would provide the care verification for a client on the needs eligibility requirements and the progressive evaluation process under risk factors? And Anessa said WellPoint can verify those through provider one. And then so the client would know that they have these assessments and by whom performs them. Um, Darren's point is a really good one. The documentation, the wet signature and that kind of thing is required because the individual receiving services need to know that they're receiving the services. I do know that if there are occasions when I've talked to individuals doing fidelity reviews and done an interview and talked about foundational community supports, the people have no idea what that means. And so it's up to providers, it's up to the staff working with them to be very clear about what we're doing, our assessments to get you into foundational community services, supported employment and or supportive housing. Because if you don't explain to them, they're not going to know. And so that's a really important piece of things that I think sometimes we might not consider. It looks like there might be a hand up, but I'm having
Looks
problems.
like Diana Sanchez.
Yes. I have a question. Um, I have a client who had employment services. You would check online with WellPoint. But eventually, once he got SSDI, his insurance changed,
Yeah,
and then from
right.
there, he was no longer eligible for employment services.
Because probably he had Medicaid, and then when you're on Social Security disability income, because he worked, he paid in the system, now he would transition over to Medicare. Sometimes people have dual insurance, Medicaid and Medicare, but sometimes that new amount would not make them eligible, that their benefits they would draw down from SSDI and then be connected with Medicaid.
Okay.
But
What
there
could he
is
do if he still looking for work? Yeah, because it's kind of made him very like upset that he lost his services.
I
So
would suggest Division of Voc Rehab because they can work with folks based on the disability, not whether they're on Medicaid or Medicare. So that could be another way to kind of, guide the person and give them some support for that. Is the person working when they made
No.
that transition?
No, we were still looking for work at the time it
okay.
happened.
Yeah.
That's unfortunate. So one of the situations is if a person has been, yes, Chris, they need HWD. I see Chris Pedroza
Mhm.
put in
Thanks,
the,
Chris.
and that is in fact the case. If a person has become employed and ends up being on their SSDI to get switched over to Medicare, they can apply for healthcare for workers with disabilities. In the state of Washington, it's also called Apple Health for workers with disabilities. The requirement of which is that the person has to have been disabled per the federal guidelines, per the federal definition. Um, Typically, that means, if they're receiving SSI or SSDI, they meet that definition. But even if a person hasn't gotten SSI or SSDI yet, they can go through the disability determination process and be found, potentially disabled, and then apply for healthcare for workers with disabilities, which is also called the Medicaid buy-in program. Person has to pay an insurance premium to all intents and purposes, and then they get Medicaid, but they have to be working. And so it sounds like the person that you're talking about isn't quite there yet, which is unfortunate.
Okay. Okay. I'm a little bit confused still. So there's not much he could do right now.
Well, as Darren says, they can be referred to Division of Voc Rehab. If within your agency you have other sources of funding that might cover continuing to do supported employment, then that would be something that could be done. I see Andrea says direct them to WorkSource. What I found is that there are times when folks with disabilities have a difficult time with WorkSource. And so sometimes require people to go with them, staff people to go with them in order to kind of navigate the WorkSource process. So I agree with you, Andrea, but be aware that that person might need extra assistance in order to navigate their system, because sometimes it's not as easy
Okay.
for somebody with disabilities.
And just to
I
add,
actually could apply for.
Diana and everyone else, I would recommend too, if there's a case like this that is where you're challenged, where you're stuck, please feel free to reach out to Darren or I or Anessa. Kind of outside of this, we're probably not
Yeah.
going to spend as much time as we'd like to in this, but absolutely email us, and we're happy to set up a Teams meeting and discuss in greater detail, what you can do to help
I
the
think I would.
person. So please do.
Okay, thank you.
All right.
switching gears over to housing assessment.
Do we need to go through the housing assessment, or are you all getting the kind of general idea in regards to how it looks?
Housing is a bit significantly different than
Yeah.
employment, as I found out recently.
Well, maybe Anessa can go through that one.
For the sake of time, though, we're already half an hour in, and I know we have a lot of other stuff to
Yep.
cover.
Yep.
We can pull the group for that one, though. Do we want to go through the housing one? Do we want to just move on to everything else? The housing one just has more pieces in it, basically, more like comprehensive questions. I see two different answers. Okay, keep moving on. Somebody's saying yes to housing. We're getting majority moving on. If anybody would like to like meet separately to talk about the supportive housing assessment, we can totally do that. Just send me an email. But yeah, for now we will move on.
All right. One more slide, please. So one of the things that providers that have been providing services for a period of time may have experienced is that sometimes WellPoint will ask them for additional information. An example being one of the agencies here in Spokane has done a number of exceptions to the rule. They work with a lot of referrals from ALTSA and individuals that have significant needs that blow through their units of service in the 6-month period until they have to ask for more. There have been a number of times when they're asked for backup documentation. And so things like the email that was sent originally that was requesting the exception to the rule was something that they had to start saving. I bring this up as an example only because I want you to consider, are there things that you might need to bring back up again? And if there are, have you saved them someplace you can find them? Because what this agency found out was they hadn't saved all of those things and they had to go back and go through their system, recreate some things. And so part of the keeping your behind out of a sling is making sure that you have all the documentation that you would need to justify what you're doing, and particularly if you're doing something like an exception to the rule. Does that make sense? And yes, Jenny, I see it is possible for folks to be authorized for both housing and employment. Awful lot of agencies do that. One thing that we would ask if you do that is that both the individual placement and support, the supported employment evidence-based practice, and permanent supportive housing would like to see, if you do that, you have 2 different staff. That it's not one staff that does half housing and half employment, but one employment staff, one housing staff. And I can go into detail about that, but the truth of the matter is a person gets pulled too many directions when they end up having to do both on a consistent basis. Now, we do understand that there are some agencies. Yes, Alana, absolutely, because they're 2 different programs is right. There are some agencies that have to start out with a staff that's part-time and supported employment, part-time supportive housing, but we encourage changing that as soon as an agency has enough income to hire staff to do the program separately. I say separately and together. So Anessa's looking at me. I can see her. We dovetail the 2. We want staff to work closely together. The person gets a better service that way. They get a wraparound service that way. But they are in fact separate programs. Avoiding supplanting. Does everybody understand supplanting? or anybody not understand supplanting. So essentially what it's saying is if there's another pot of money or another program that could pay for the service, and you've been using that other program, then you should continue using that other program. FCS is one of those kinds of things. Medicaid is one of those kinds of things wow, I need to finish drinking my coffee. That says that they're the payer of last resort. DVR says the same thing. So in all intents and purposes, what that's saying is if there are multiple pots of money that you could draw from the one that makes the most sense, and don't end up using more than one pot of money for the same kind of service is another one of the issues. Vanessa, do you have more to add to that? I see you nodding a little bit, but I think I'm not doing the best job of explaining it that I could.
Um, just that we know this can be a little bit tricky to navigate because lots of times, and this is what we recommend too, providers will utilize multiple different sources of funding, multiple different programs. Obviously, different participants qualify for different things. Sometimes it can be helpful to separate out roles. So like, for example, rather than having somebody who is serving both HEN and FCS folks, having those be two separate roles, just like with having employment and housing be two separate roles, can be really helpful to ensure like clients aren't getting overlapping services that would cause supplanting. This is something we're happy to have like a more in-depth discussion on the side too, if anybody has like specific questions about, you know, their company's situation, we're happy to meet about that as well.
And I will say, so when you've heard the term Medicaid fraud, at times that happens because you're billing two different sources. That would be a form of supplanting. A DVR comes to mind with that. In supported employment, if DVR is working with an individual helping them find a job, then an FCS agency can't also be working with them finding the job. They might be doing some case management kinds of things with the person. So maybe DVR is helping them find the job, and the FCS provider is helping them find daycare because that's a need, or figuring out transportation, or buying interview clothing, or things along that line. So there are times when two agencies might work with the same person doing two different services. I see it says, so if someone has HEN, does that mean they can't do FCS SH? Vanessa, I'm going to leave that one to you. So housing and essential needs.
No, that is not necessarily the case. Where that gets tricky is there's some, well, I don't know. Dawn, how deep are we diving into fidelity today? I don't want to go off on like a whole tangent and get us distracted, but I have,
we're going to talk briefly about billable services, not so much about fidelity, but the fidelity items that are in fact billable services are in, we have housing and employment slides on both of those.
I would be really careful with doing both HEN and FCS for the same client, just because some of the services are very similar. As you'll see when we talk about, these are some billable housing services. It's also tricky if you are trying to follow the evidence-based practice, which obviously your agency should be doing if you're providing FCS services. HEN and FCS do not perfectly align together. For example, HEN requires that participants who are enrolled meet with their case manager once a month, and FCS says you cannot put any stipulations on somebody's housing based on their engagement with services, right? So with FCS, we cannot say you have to meet with your case manager once a month to keep your housing, but HEN, on the other hand, does have that requirement. So it can be very messy there.
Yeah, and I see a question about HEN as a qualifier for eligibility in employment, though. Yes, that's right. Housing and essential needs. I see Jonathan says, every time I refer out to DVR, they put the member I'm serving back into my lap. They've yet to find him a job. So IPS, Individual Placement and Support, encourages working with Division of Voc Rehab because nationally, Division of Voc Rehab is the entity that is tasked with helping people with disabilities to find and maintain employment. The reality of DVR in the state of Washington is that they're on order of selection, which means they are only serving, they have, I think it's 7 categories, 3 categories that have some subcategories in them related to the level of disability a person experiences. And right now, they're serving only what they term most significantly disabled, which means there's a bunch of folks that end up on a waiting list. And so, Jonathan, I think what you're experiencing are those folks that are not eligible because they're not in that most significantly disabled category. And they do refer back to FCS agencies, which I'm thankful for, because then the person at least has the opportunity, or Austin, it looks like, is the person that said that. The person has the opportunity to find and maintain a job. I would still encourage people to refer to DVR when the person wants to be referred and when it's a service that they need. But just know that we have a lot of other challenges in the state of Washington that relate back to that order of selection, sadly. And I see Erica says, is one client working with WorkSource and FCS supplanting? No, it's not, because WorkSource doesn't provide the same level of service that FCS does. WorkSource more often than not just links with resources, links with the kinds of training and things that WorkSource provides, or the system for applying to employers or things along that line, whereas FCS actually provides the assistance in order to do those kinds of things. Not to mention the fact that WorkSource is a free service. They don't bill anybody for what they're providing. And so that's probably the bigger issue than anything. It's not supplanting because they're not charging anybody, but the FCS provider is charging Medicaid to provide the services. I hope that helps. All right, data collection. Does everybody collect data? I'm hoping the answer is yes, and that's a kind of rhetorical question. I want to say, and I'm going to go out on my little soapbox here for a minute. If the legislature, if Medicaid, if those folks that provide us with funding to do what we do, want to see whether they're getting a big, good outcome for their money, how are they going to do that if we don't collect data? How are they going to do that if we don't have the data that shows how many jobs or how many houses are gotten through participation in a program if we don't collect data? We have to collect data. And that data also includes success stories, because the numbers don't tell the whole tale. Sometimes the success stories too do. And so I'm encouraging you, if you're not collecting data yet, that you need to. If you have problems with kind of figuring out how that goes, reach out to us and we can surely talk about tracking systems, electronic health records, and what some other agencies have used. Connect you with somebody that's using an electronic health record that helps to collect data, or whatever we need to do. But hear me when I say, if you're not collecting data yet, you need to. It is a keep your behind out of the sling kind of a thing, because it's part of what's going to help us justify the need for funding ongoing. I see Wendy said, my son had to go to DVR to get referred to Peninsula Services, which is the work agency I wanted for him, but DVR has to do the referral. They paid for work clothes. So one of the things about DVR is that the voc rehab counselors typically aren't the ones going out and looking for jobs for folks. They manage the cases, but they don't go out and actually look for the jobs or do the job coaching when a person's gotten a job. So DVR contracts with agencies that they call community rehabilitation programs, and some of the agencies you work for may be a CRP. But the agencies, the CRPs, are the ones that actually go out and do the work search and the job coaching and those kinds of things. All right, next slide, please. And there we go. Karen, do you want to grab this one?
Sure. So FCS services are broken down into two sections. This one is the pre-employment services, and we're really focusing on building that relationship with someone, building some of that trust so we can really get to know the person. We have a great employment assessment at the IPS Employment Center worksite that you can download and use as your own. We really encourage that because it encompasses a lot of the different principles of IPS in that, but it's also a great way to kind of start collecting that information and learning about the person's strengths and look at some of the transferable skills that we're doing. And we really encourage this to happens over a couple appointments. I've seen people blow through assessments in 20, 30 minutes. It's really hard to get to know somebody in that shorter time to really figure out what their goals are, what their passion is, what some of the barriers, some of the things that might cause some anxiety in the job search. So really encourage people to kind of use this and, use it as that relation building pillar of the services you're providing. We really focus on those person-centered services that we want to find out what the person wants to do, what they like, what they don't like, what some of the success may have been in the past, what some of the challenges they've experienced, so that we can use that and develop a new plan, to look at some employment goals. We really want this individualized, not what Darren thinks the person should do, but what the job seeker wants to do. Maybe it's a survival job. Maybe they have a very long-term goal that could be complicated, that might need a certification or a degree. So it could take a lot of different steps to get to where they're at. Or maybe there's something in between where they have some skills and abilities and they're looking for the right work schedule, right salary, those different things to balance out their choices. FCS also supports what we call job carving. When you go into an employer, maybe you have a relationship with them and look at customizing a job or some employment tasks to take tasks off one employee and provide it to this new employee in this new position, and customizing those type of tasks that can meet the needs of the employer and meet the needs of your job seeker as well. We've talked a little bit about the importance of benefit education if you're on SSI or if you're on SSDI or maybe HEN, ABD, food stamps, all of those benefits. Whenever there's some subsidies, well, not subsidies, whenever there's some federal or state benefits that somebody receives, earned income can impact those benefits. So it's always good to educate people what's going to happen next. Just in the case we heard earlier about somebody transitioning off Medicaid into a Medicare-based program with SSDI, kind of look at what those work incentives, because they will need to know some of the limits within that system on how to maintain benefits or maximize work and maintain some of their benefits. Definitely transportation. I've seen a lot more transportation challenges in Eastern Washington than in King County where I'm at, but still they exist. And we just want to caution people that just taking somebody from your office to the pharmacy, your office to an employer, that's not a billable service. But if you do kind of the interview prep in a car or kind of a check-in, and you can craft that medical necessity note. Maybe they're a little anxious, maybe they could be a little sad, maybe they're apprehensive, whatever that looks like for the individual, you could craft that into a note, but it's not designed just to ferry people from one destination to the next. We really focus on building that rapport. We want to get to know people, and we want them to feel safe where they can share information with us to keep that two-way highway open of information exchange and really get to know where people are at for that. And I always want to look at the barriers and some of the challenges, maybe some of the trauma that could have happened at jobs. I've worked with a lot of people who have had trauma experiences in their employment and don't want to go back to a large factory kind of organization, want something smaller that they can feel comfortable because of the environmental is overstimulating for them. So kind of learning what those different things are for folks. And we can't emphasize enough about collaborating with your team internally, externally, to really help the person move forward. Maybe you're working with a work source, maybe with DVR, making sure different organizations kind of know of some of the things that you're doing to really pool resources together to make your job search successful. Anything in the chat about pre-employment services? Otherwise, it's
Not at this point. Nope. I do see, where can we get or see what is billable? these services that show up as billable, if you note on the slide, it says WellPoint contracted services. It's in the WellPoint contract. You'll be getting the slides today. I would love to say that I know how to put them in the chat. I don't, so I'm hoping either Nessa or Darren will put the link to the slides in the chat for me. But where you see it says WellPoint contracted services, the billable services are actually in the WellPoint contract, and they're what are included in these slides. I see Nessa's doing a thumbs up, so thank goodness I have tech savvy colleagues, because that ain't me. um, there's some overlap between the pre-employment services and the employment sustaining services. You'll see the same thing with the housing stuff. Career advancement. One of the things that I love about IPS is it's not just about getting any old job. It's about helping a person to get the job they want, and in some cases about short-term goals and long-term goals. I've had lots of folks that, maybe got a job at McDonald's because they needed to keep a roof over their head, but in the long run, they wanted to become a nurse or a welder or something that required going to college. And so IPS is all about the idea of helping a person to achieve those short and long-term goals. Helping people to attend school, providing academic supports when it's their preference. I know it isn't an intuitive per se when we talk about supported employment, that it also includes supported education, but it does. Whether that education is college or a trade school or a, flagger program or high school or GED or whatever it might be, folks need supports sometimes to achieve those goals as well. Negotiation with employers, job accommodations, and assistive technology. I don't know about you guys, but I am not a pro in regards to knowing what job accommodations a person might need. Darren and I have got a lot of information related to resources that you can use to sort of look up what job accommodation might work for a person or what kind of assistive technology would be a viable option to help them. I will also say some of it's kind of common sense. If a person has a high level of anxiety and they need to take breaks at times that are a little less scheduled than their colleagues, that would be a job accommodation. If they need to be able to leave the sales floor for a few minutes to calm down and then come back, that might be a job accommodation. So some of the things are, obviously all of the things are based on the needs of the person, but some of them are a little more common sense. Some are a little more expertise related in regards to having the knowledge about job accommodations. We can connect you with those resources as necessary. Job analysis is pretty much what it sounds like. When a person's interested in a job and they're not sure of the what a job entails, the job analysis goes through how much standing, how much lifting, how much interaction with others, just the real specific pieces of what does a job entail in order to be able to make that good match with a person. Or if they've gotten the job already, kind of determine where they might need additional assistance, the areas that are going to be of the greatest challenge for them. Job coaching. I want you guys to notice it is a contracted service that any FCS provider is contracted to do. I hear some folks say we don't do job coaching. You're supposed to. It's the only way I know how to put it. That is part of the package deal. And so job coaching can be on-site with a person. It can be off-site. DVR I thought was pretty brilliant. A few years back, a lot of folks with mental health issues or invisible disabilities may or may not want their employer to have kind of all the details about that. And so there have been times when folks have said, I don't want you on site with my employer. I don't want you to talk to my employer. Job coaching can still happen, but it then ends up being off-site. It ends up being phone calls or maybe meeting with them in the parking lot during their lunch break, or, going and grabbing a cup of coffee during their lunch break, or whatever it might be. But traditional job coaching is assisting the person not so much to learn the job because the employer should teach them how to do the job, but to help the person to know when they need to ask their supervisor for help, or how do they interact with their colleagues, or just a variety of things along that line. Always placing the emphasis on the employer should be the one teaching the job. The job coach should be teaching the kinds of things where a person gets stuck otherwise, like how often do I need to talk to the employer at what point, or how do I interact with this person, or my breaks, how do I know to get back on time, or just a variety of things along that line. Benefits education and planning, Darren already talked about to some degree, and I would say I bow to Darren. When I have benefits education questions, I go to Darren. So there's your prompt to use Darren for that kind of thing too. I've had the training for certification for a benefits planner, didn't go through the process of doing the case study and the testing. So I am not a certified benefits planner. I do have a lot of information, but Darren has more. Asset development truthfully talks about personal assets, learning, new skills and things along that line. But it's also about sometimes folks need to move on to other jobs in order to be able to get a better living wage. So it's some of each. Ongoing follow-along supports. I would argue that we're all interdependent, that we all have support teams. And part of this relates back to that. The folks that we serve should have support teams too. I have, my family members that I can talk to and friends, and Darren and Anessa are part of my support team also. But when I need to kind of noodle through things and figure out what I'm doing, or just to vent a little, we need those kinds of things. And so at some point in time, once the person has gotten the job, but they maybe still need those kinds of supports, have we helped them to develop them? Have we helped them to connect with colleagues or natural supports or whatever? Questions about either of these two slides? All right, next slide, please, Darren. And I think it actually might be housing, and I don't know if it's the real Anessa or a different Anessa said be right back. So the same kinds, I'm just going to yammer for a minute and she'll catch up with it when she comes back. The same kinds of things that you saw for the pre-employment employment sustaining being billable services, those parts of things are the same thing with pre-tenancy and tenancy sustaining services. These are the kinds of things, if you're doing supportive housing, that you're going to be billing for. It's interesting to me to look at things like landlord liaison. I will say that landlord liaison and job developing, talking to employers about jobs, have a lot of the same principles. It's relationship building. It is getting out and getting face to face with those folks, whether it's a landlord or an employer.
Hey Don, I'm back. I can keep going if you want.
Yay! Thank you.
There's lots of ways that you can support folks prior to them getting housed. I'm not sure what all Don covered yet. I heard some pieces about landlord liaising, building relationships with landlords. That's super important. I do want to emphasize, after your relationship with the participant, the relationship with the landlord is definitely the next most important. You want to be able to get to a point where landlords are calling you, offering you units for people, rather than having to constantly be the boots on the ground searching for open units. And just making sure that you get across to the landlords that you are a resource for them. They can call you. Make sure you've got lots of good conversations with participants and talk about disclosure and things like that, just like Don was talking about with conversations with landlords, so that participants are aware of what kinds of conversations you might be having. Any kind of conducting assessments. We really like to see that housing assessments are really robust and include questions that are going to help folks think a little bit deeper about what kind of housing they want. Lots of folks, especially if you're working with somebody who has been, chronically homeless for years and years, they might tell you, like, I just want to be indoors somewhere. I don't care where you put me. That's probably not actually true. There's probably a few things that they want to consider with their housing, and a good housing assessment should help kind of get to the root of that. Like, what kind of neighborhood do you want to live in? Or if you've been housed before, what did that look like? What does your dream housing situation look like? What are like absolute deal breakers for you? Like, we should not look into this kind of housing or in this area. Helping develop community supports is really important as well. This can be helping folks build natural supports. This can be helping folks utilize other services. Like, for example, if you're helping them with housing, but they also need to get connected to food resources or a primary health provider, or they want SUD treatment or something like that. Those are all things that you can help them with. Treatment planning, establishing short and long-term goals. Just like with employment, it's really important that treatment plans are really regularly updated. Anytime somebody meets a goal or changes course on something, or wants to explore a new area of treatment or service, all of that should be reflected in the treatment plan. We'll obviously talk more in depth about those, but we call them a living document. And when we at HCA, come in and do a fidelity review or something like that, we want to be able to see the participant is very involved in these. These treatment plans are really being used to inform services every time you're meeting with somebody. Financial skill building and benefits support as well. Dawn, I don't know how much you talked about these already, but I always like to point out if you are working on employment things with somebody who is only authorized for housing, you can bill for that underneath housing, because obviously we know if somebody is employed, they're going to have a steadier income, they're going to have more income, that those kinds of things are going to help them be more likely to be able to maintain their housing, right? But it does not go both ways. You cannot bill for anything anything housing related under employment. And then any kind of benefits support as well, especially, helping folks navigate things like, how do you report when your income changes, if that's going to affect how much rent you're paying, or how might starting employment impact the benefits you have and impact your housing. That kind of thing. All of those things are going to be really important in supporting folks prior to them getting housed. And if we could go to the next slide, please. Getting somebody housed is really only half the battle. I would say arguably the easier part of the job. Helping folks maintain their tenancy can be a lot more challenging. Just like with pre-tenancy, coordination of care is going to remain really important. It's very important, obviously, that everybody on the care team is looped in. Everybody's aware of what the participants' goals are and what their role in helping is. I do want to point out too, coordination of care is a collateral service, as is landlord liaising, meaning that the participant does not have to be present in order for you to bill for that service. Like, so for example, you are in your office, it's 9 a.m. on a Monday, a landlord calls you back about, about something relating to your participant, right? The participant's probably not sitting right next to you, but you can totally take that call with the landlord, talk to them, get information from them, and still bill for that, as long as you then obviously relay that information to the participant, and you can explain, in the documentation why they weren't present. We know that coordination of care, it's not always possible for the person to be physically present, even though that's the ideal, right? But that's totally billable with or without the participant. A lot of the stuff on here is pretty similar to pre-tenancy. I do want to point out though, you'll see employment and or vocational support on here. I've worked with lots of folks that once they were housed and felt comfortable and safe and stable in their housing, they just kind of didn't know what to do with their time. A lot of people reported feeling very bored, feeling lonely, just kind of unhappy. Like, I don't know what to do with my day, right? That can be a really great window into bringing up, like, hey, are you interested in working and finding a job? What do you want to be doing with your time? Do you want to have more money? What kinds of things are you good at? What kinds of things are you interested in? Those are all really great ways to open the door to that conversation. Obviously, we know if we just ask somebody straight out, like, are you trying to get a job or something like that, that might scare people off. A lot of our folks might not have had employment recently, might be very intimidated by that process, might be worried about losing their benefits. All of that is totally very understandable. And there's better ways to approach that conversation, right? Informal community support development, that can be things like, how do we navigate the bus route in your new neighborhood? What's the best route to get to your grocery store, to get to your gym, to get to the food bank, any of that kind of stuff. Or that can look like, how do we navigate conflicts with our neighbors? How do we make friends with our neighbors? What is walking distance from your new place that you might like to enjoy doing? Anything like that to help them integrate into the community is going to go a really long way in maintaining housing. Development of independent living skills is really important as well. With this one, I want to point out it's ideal when it's okay with the participant and when you're comfortable with it to visit people in their housing, because this is going to get you a really good window into what kinds of things they might need help with. Like, for example, I have housed people who are, chronically homeless for 20, 30 years. They didn't realize that you need to have a shower curtain up when you take a shower in your place, right? And if you don't do that, and if you don't do that for long enough, you can cause really significant damage to the units below you. And then that's going to cause you to get evicted, right? Because you've caused $20,000 worth of water damage. Or conversations with folks about, like, hey, how do you store your food after you're opening it? Like, do you have Tupperware? Do you know that, like, these are the things that need to be refrigerated? Or how do we cook with all of these, like, dried beans and rice that we're getting from the food bank? Let's talk about, like, how we can make some recipes out of these things. Anything like that is always great for meeting with folks. Treatment planning, again, is really important. That continues to be really important. Increasing ADLs too. Lots of folks qualify for caregiving services, but can't access them when they don't have a regular address. So maybe completing a care assessment with somebody once they move in, that can go a really long way in, making sure they are able to maintain the cleanliness of their unit in the event of inspections, or, prevent them from not having access to, like, clean laundry or food if they need assistance with those kinds of things. Any questions about pre-tenancy or tenancy sustaining services? All right, we'll move on to informed choice. Informed choice means the person you're supporting is able to make decisions based on all of the information that you've given them, right? So we don't want to keep any information. We don't want to hold any information back. It can be really hard when we care about our participants, right? We want them to be able to have access to, sometimes we get a little bit too invested in what the choice is, right? We might think, like, oh, they really need to do this, this, and this, and then they're going to be fine, right? We don't want to hold any information back based on what we think they should be doing. We want to give them all of the information that they need to make an informed choice. We don't want to let our biases interfere either, which can be really tricky sometimes, right? But the analogy that we use for this is the GPS and the driver. We are acting as the GPS, the participant is the driver. We are presenting them with all of the different possible routes that they can take. How long is it going to take? Are there potholes? Is there construction? What are the pros and cons of all of these different options? And they are ultimately the one making the decision because they're in the driver's seat, right? We can totally tell them, like, I'm a little bit worried about the choice that you're making here, and here's why. And we also need to convey to them, we are here to support you no matter what, regardless of what choice you make. And even if it ends up going poorly, like maybe they end up getting evicted, we want to be able to tell them, like, yes, we are still supporting you. We are going to get you housed again. Being non-judgmental in that kind of situation really goes a long way. And yes, Sam, you're absolutely right. This is so difficult when substance use is involved, right? Like, for example, when you're housing somebody who is working on getting sober and they want housing in an area that there's lots of drug activity, right? It can be really hard to move somebody into that kind of situation. And ultimately all we can do is say, like, hey, I'm a little bit worried about how you're going to maintain sobriety. when there's multiple people in your building that are using substances, right? But yeah, just again, that's what the informed choice piece is, right? We are giving them all of the information. They are the ones making the decision. We don't want to put ourselves in the position of making choices for them, because then it's our fault if it goes wrong, and it's taking away a lot of autonomy from them as well.
I will mention too, Anessa, that, and I'm not sure if we're going to get to the document, one of the documents that individual placement and support recommends using is called a disclosure form. It actually guides a conversation with the person about, what are the pros of making this particular decision in regards to disclosure? What are the cons? What kinds of things, if I'm going to talk to an employer, or for that matter, a landlord, what kinds of things can I tell them about you? What kinds of things do you not want me to tell about you? Can I even talk to a landlord or an employer on your behalf? So part of this informed choice decision is that disclosure conversation. And there is an actual form in the ipsworks.org site that guides that conversation and allows you to document it too. I don't know about you, but when I had a caseload of, 20 was ideal. At one point in time, I had a caseload of 40. There was no way I was going to remember what everybody had said about what I could disclose, what I couldn't, and that kind of thing without having it documented someplace. So that's a form that's available for use. Next slide, please, Darren. So I think because we have so many documentation conversations to have, we might just skip this slide for today. It's in your slide deck if you want to talk about and probably oh no, we will talk about this one. Darren, did you want to address this one, or Anessa, or would you like me to? We're sort of going back and forth, but I like giving it to whoever feels that they best have the best explanation for it.
Can I take the next slide? Because I really like the next one.
Okay, that's fair.
You can take this one, and then you can add what I might miss, Dawn and Anessa. So kind of looking at, two sides of the equation. We have, the agency, the administration, the supervisors, the directors, and we also have, the service delivery piece where the direct service folks and supervisors really come into play. And, CMS is a federal organization, for Medicaid standards. So the administration really needs to include that risk management, the quality assurance piece, to make sure that they're meeting the guidelines that the Center for Medicaid Services has around documentation, which ties in, to FCS services and WellPoint in the HCA. And, we talk a little bit about disclosure, but we also have to be sensitive about HIPAA compliance, that we don't want to share that individual personal medical information with anyone without having that conversation with somebody, what they're comfortable sharing or release to. When I was a job developer, I worked for a behavioral health agency and had a really long name on my business card. So I was already disclosing what I did in the field and who I work for. Not everybody's comfortable with that. Some people are very guarded, and rightly so, about information that's shared. So it's always important, to look at that, as well as administration being able to have some oversight and some rules about what can be released. And that's why we have a lot of release of information to educate the person about information that's going to be shared between entities. We've talked a little bit about the services with FCS. Definitely encourage everybody to look at the FCS manual because it has a lot of valuable information about policies and procedures. Right now on the employment side, we're actually working on some documents for folks to help onboarding for the supportive employment side of policies and procedures. And I know supportive housing has already had that. I think that's located on the Pathways to Housing website if you need to access that. I always encourage people to build that relationship up with your FCS manager. That we get a lot of questions, but sometimes it's the questions about availability, billing, some of the how come we haven't been paid or what happened to my referral. Those are definitely, the focus on WellPoint. And I think it's really good within your organization to have a point person. So you have that one person building that relationship to support the team. And I think Don talked about data, Darren talks about data, and Essa too, that you should have some trackers about who you're working with, but also to look at authorizations and to see how you're utilizing them. I think I was just looking at a report that came out. We're still about utilization about 3 hours per month of SE services, a little bit higher for supportive housing services. So definitely a little underutilized. And I think it would really help programs if they really had a tracker so that you could look at what your current authorization is, those hours remaining, and look at who's going to end, who you're going to ask for that extension, for ongoing services for new authorization or sustain the authorization, or who you're going to decide maybe they're not no longer need our services, so we could close out and end that authorization. Get to know Provider One. It's your best friend working with FCS, and it is the way to look at verifying somebody's Medicaid. So definitely have somebody proficient in that and who knows how to reach out to Provider One for any questions. On that service delivery side, we're really looking at those individual services that are providing, how we do the documentation, what kind of elements we need. We've already talked about some of the health risks, some of the social determinants of health, some of the health needs, all that wraps around into meeting the needs of the individual. And both of our services for employment and housing, we're really focused on those evidence-based practices because following these practices give our participants better outcomes. And what a better way to invest in the system is a system that creates better outcomes for housing and employment for all our folks. My favorite quote is, if it's not documented, it never got done. So be aware that this is a document that I think Chloe had some questions at the very beginning of if there was a system-wide audit, what are they going to look at? They're going to look at the individual documentation. They're going to look at the forms, how you complete those. Is everything tied together that, provides that support for somebody to get the services, and also for your staff. Do you have a log about training? That there's a lot of trainings like we do today. We have a lot of stuff on our YouTube channel. Are you tracking as a supervisor the different trainings that people can be part of and complete? And again, Provider One can be your best friend. And all services should be intentional. We just don't want to lead people along. I've had people that come into my former employment program. It's like, Darren, what are you going to do different for me than the last organization did? Well, we're going to focus on your goals. We're going to listen to you, and you're going to kind of lead the direction of employment opportunity. So we don't want just people to come in and say, yeah, we're going to help you look for work. 4 months later, 5 months later, 6 months later, there's no resume. There's no engagement with employers. There's kind of no plan for engagement for employers. So for high fidelity, we want that process to happen in, 30 days. But we know sometimes it takes a little longer, but at least to have that kind of, plan that whatever services we're going to do, we're going to engage the person. And then that next step is engage those partners and providers out in the community, whether it's WorkSource, Social Security, DVR, employers themselves, maybe some training and certification through some of the community colleges, whatever that look like, that we're actually following through what's the services that we're sharing with folks. I see Christopher had a great question about rack codes. Yeah, there is a document on the FCS website for the codes. I think it's helpful with Provider One because not all codes create eligibility for the FCS program. I think there's a lot of information that's definitely beneficial for benefit planners. I'm not sure if the rack codes comes into that, but I think it's always good to know the different codes within FCS. And that's a great question to build up that relationship with your FCS contract manager to make sure that they align. Or there might be something to do in terms of planning, in terms of how to get somebody in the correct Medicaid. So that would open the door to services. Any additions, Don or Anessa?
Yeah, I was just, Christina had asked, or had said, I use a Google Sheet for tracking. Is that a good way to track? I think whatever way works for you is a good way to track. If you're lacking a document or a system to be able to track things, we have what we call a participant log that was developed well, just prior to FCS when we had Best Grant pilot sites. And it actually tracks a number of things in one Excel document. It's got two tabs, but one of the tabs tracks kind of per participant. When's their authorization ending? When was their date of entry? When did they start going out talking to employers? When did they get their first job, for supported employment? And then there's a second tab that is for staff to document. Here's the job development I've done. Here's who I went and talked to on the date, name of the employer, was it a hiring manager, all that kind of stuff. So if you would like that document, reach out to us and we can surely get it to you. I know there are a lot of agencies that are using electronic health records that have ways to track too in the reports that you run. So it would be very individualized to your agency. If you're having difficulties with that, definitely reach out to us and we can see if we can help you to come up with a method that works for you. I see a couple of folks say that they would love that document. So maybe Darren or Anessa, my far more adept folks at technology, if we can put the link in the chat, that might be a good thing to that participant log. All right. So next, please, Darren.
Just to back up, I think that's on our Pathways to Employment website. Is that the document you're referring to, the tracker, Don?
Yeah, it might still be. So where I said on the outline that the Pathways to Employment and Pathways to Housing links were active links, excuse me, if you go to the Pathways to Employment site and look for participant log, if you're having any difficulty, well, let me back up. So when you get to Pathways into Employment, there's multiple tabs, if you will. If you look at, I think it's the provider tab, and then there's a tools link or a tools tab under that. The tools includes the documents. If you have any problems at all finding it, let us know and we'll get it to you. Next slide, please, Darren. And one more. So keeping it intentional, I know we all have kind of input to give related to that. What I did when I met with individuals is I would look at, as they were coming in, what does their treatment plan say that we're supposed to be doing today? But what I would do through the session is we'd work on whatever it was. And when we got to the end, I would say, okay, let's reschedule. What are we going to be working on next time? So I very much got the person's input. If it was already in the treatment plan, great. If it wasn't, that was a kind of a trigger to me to say, gosh, maybe we need to update the treatment plan because this is something different that they want to work on. I wouldn't let it change session to session to session. There had to be some continuity to actually make progress. But if something new came up when I did my planning and scheduling, then we talk about the next time, do we need to add to the treatment plan? So keeping it intentional really in my mind just means both you and the person are on the same page. You're working on what they said they wanted to work on. You have a treatment plan goal that has some measurement that when you've accomplished it, and that you're talking about planning on a regular basis. You're keeping in mind the treatment plan and does it have to be updated. That's not to say you can't deal with the emergent scenario of the moment. So I worked for a behavioral health agency for 21 years. We had a number of Medicaid audits during that period of time. Interestingly enough, Medicaid auditors all go by the same set of rules, and sometimes they interpret them a little differently. But what I heard from more than one Medicaid auditor is if an emergent situation comes up, yes, you can address it in your session. If it comes up more than one time, you better probably get it in the treatment plan. You could still address it in a session if it's a one-time thing. But that's not the way every session is supposed to go. It's got to be back in the treatment plan, if it's going to be an ongoing thing that you're addressing. So keeping it intentional, you got to both be on the same page. You've got to not be willy-nilly about just talking about whatever happens at the moment. There's got to be some rhyme and reason to it, and that's got to show up in the notes, in your session, in talking with the person, in planning, all of that. The what can we bill for? You ended up seeing in the slides about the pre-employment and employment sustaining, pre-tenancy and tenancy sustaining, the well-point billable kinds of things. But we're going to talk more about when we are doing services and we're going to bill Medicaid for them, there has to be medical necessity. We're going to talk more about that. Medical necessity, just kind of going back to why do they need our service? If they could get service from just WorkSource and run of the mill, then that's what they do, but they need more help than that. So why are they coming to this? What additional help do they need? That typically ties back to the medical necessity. Golden thread, Medicaid, and I don't know if Medicaid coined the term golden thread. It's certainly used in conjunction with providing Medicaid services because there's a very systematic way of assessing and then treatment planning and providing services and documenting those services that has to happen in order to qualify to bill Medicaid services. Thanks, Marcus. The video will go out to you. I see Marcus is having to leave. Next slide, please, Darren. Anessa, Darren, do you want to cover this one?
Sure, yeah, happy to. So when we say intentional service delivery, that means purposeful, deliberate, and planned. And this goes back to what I was saying earlier about how every interaction that you have with somebody needs to be directly tied to their treatment plan. First of all, that's how it's a billable service, is that we can see when you meet with somebody, you are talking to them and working with them on a goal that they identified that we can see in the treatment plan, right? The interaction is directly tied back to the course of treatment. And the treatment plan can help you as a provider map out exactly what you want to cover during your interactions with somebody, what direction you're going in with them. We don't want to fall into a pattern of, especially maybe with lower needs clients, just kind of meeting with folks to check in on them, right? Anybody can check in on them, stop, chat, say hi. It's totally fine to have some interactions like that. And building rapport is, also a billable service. And it's really important that the documentation shows that you are accomplishing things when you're meeting with people. There's a plan laid out. You talk about what you're going to do between meetings, what they're going to do before your next meeting. The treatment plan should have very clear, like SMART goals, right? Where there's specific dates on the goals, and those kinds of things should be revisited every time you're meeting with somebody, right? There should be concrete steps taken each time. And this is really a great way to make sure that you're not spinning your wheels. The participant feels like they're making progress too, right? Without intentional service delivery, you might find a few months goes by and they're not any closer to finding housing, right? But if they can see every time we meet, like, oh, we called 3 landlords and I put in an application and I got a new copy of my ID. These are all concrete steps that we are taking towards getting somebody housed, even if they are still currently unhoused, just as an example. Don or Darren, do you want to add anything to that?
No, I think you did great.
Awesome. We can go ahead and move to the next one then. Okay, so services should be very individualized. That's very important as well, right? Even if you have, 20 people on your caseload that are all working on finding housing or working on finding employment, all of those people are going to have very different barriers, very different strengths, very different preferences and needs. That's why the treatment plan needs to be very individualized, and therefore your services with that person also need to be very individualized. It's important to plan what will be provided during the visit, right? Have a plan going in of what you're hoping to accomplish while you're interacting with somebody. Services other than those identified by the treatment plan can be provided, for example, in a crisis intervention situation, right? If you are working with a participant and they're having a mental health crisis, you can absolutely support them with that, even if there is not anything, necessarily tied in on their treatment plan. immediately about that, right? That's always something we can go back and fix. But crisis situations are obviously always going to be an exception to that. And services should be we should be able to see that services can be modified and are being modified, right? You might meet with somebody the first time and they tell you they have absolutely no interest in employment. And that doesn't mean you can't revisit that conversation, 3, 6 months, whatever later when it feels appropriate again, right? Folks change their minds about things. Folks' needs change depending on their situation. It's always okay to, revisit conversations about modifying services or presenting new options. That can also be a really great way to re-engage folks that are starting to fall off too. If maybe you help them with housing and they're not sure what else they want to do with housing, that can be a great time to talk about like, well, hey, like I can help you with lots of other things. I could get you connected to peer services or treatment or employment. You know, our role as housing or employment specialists can sometimes reach beyond just those specific things. Oh, and with that last point too, if services are frequently provided, the treatment plan should be modified. For example, you could do a one-off trip to take somebody to the food bank or to the grocery store. And if that's something that's happening more often, more than once, that needs to be in their treatment plan, something about helping them with food security or connecting them to resources so that they have adequate nutrition, something like that. If it's regularly happening, it does need to be in the treatment plan.
Okay, so next slide sounds like, yep. So, see a lot of folks needing to leave, and I will just mention again that we're going to send out the video sometime next week. And so if you've had to leave early, or if you have to leave early, you will still get that. Benefits of intentional services. I think really the bottom line is to get away from that following up with or checking up on and doing something, as Anessa mentioned, that keep people moving forward. Part of what treatment plans do, and I don't know that we discuss this enough, is that they give hope to the person. They can see, they have an actual visual representation of here's what I wanted to work on, and I'm making progress. And so one of the huge benefits of intentional services is we have all that documentation in the treatment plan, and it really does help the person to keep motivated, to feel hopeful because they're doing the things that they want to do and they're making progress towards that. Next slide, please, Darren. I think these are some pretty good examples of, the getting away from that lack of intentionality, going to check on Bob, and opposed to that, Bob and I are going to review how he's settling into his new apartment. So, I think these are just some pretty good examples of how you might take your documentation that says something like dropping off Mary's meds and making it something that's more intentional instead. All right, next slide, please. And I apologize, I'm moving us along a little quicker because we have quite a few slides left to do and only 26 minutes in which to do it. So, Anessa or Darren, did you want to grab this one? Can you even read it? I guess that's it. Most of the time I think we're good at putting slides together that you can actually read when they show up on the screen, but not always. This might be one of those.
I can go ahead and read. Do you want me to read it out loud?
It probably wouldn't hurt because
Because it's tiny.
my old
Yeah.
eyes can't read it. I'm thinking there may be others.
Let's talk about this sample situation here. Ralph is a 30-year-old male who has been diagnosed with bipolar disorder since his early 20s. Ralph lived on his own since his early 20s. However, he was evicted from his apartment within a year and began living with family. Ralph is close with his parents who have been supportive of him, but after discussing their living situation together, Ralph decided that he wanted to try living on his own again. Ralph states he is ready and looking forward to his new independence, but also finds the process daunting and his symptoms of his depression have increased due to the stress. So let's take a look at what a treatment plan might look like for Ralph. So the goal that we've identified based on that is in the next 3 months, I will find an apartment within walking distance of my parents' home while learning ways to manage symptoms of my bipolar disorder. That is a great goal. It is time specific, which we really like to see, right? That he's identifying in the next 3 months, I want to find housing. The first barrier identified is Ralph has difficulty coping with stress, which is causing a lack of motivation related to the moving process and completing tasks in a timely manner, right? That's a big issue for a lot of us. Getting that, what did you call it, Dawn? Task paralysis. If things feel really
Yes.
overwhelming, it can be really hard to know where to start, right? So that's a great barrier that's identified there. Objective 1, within 2 months, Ralph will create a list of available housing units as well as a simple step-by-step instruction guide for himself of what information he needs to gather to fill out housing applications, right? This is great because it is teaching Ralph how to go through this process himself. These are things that a housing specialist could support him with. And this is also giving him an opportunity to create his own instruction guide so that next time he needs to do this, or if he needs to do this again, he knows exactly what he needs in order to do it. And if, maybe the housing specialist takes him through step by step one time for how to fill out an apartment application, now he knows how to do it. He's been taught how to do it. He has a step by step guide. He can do it the next time. Intervention 1, staff, insert your name here, will meet with Ralph 4 times for 60 minutes to identify his preferences and barriers related to successful tenancy, including collecting information on and identifying housing retention barriers. Intervention 2, staff name will meet with Ralph on a daily basis to assist Ralph with reviewing available housing options in the community that meet his identified preferences and to compile a list of information and documents required by housing applications. Intervention 3, Ralph will attend a bi-weekly education and training session for 30 minutes given by staff on the role, rights, and responsibilities of the tenant and landlord. So we see here, there are pieces that the housing specialist or case manager or, whatever the title is, pieces that they are responsible for and pieces that Ralph is specifically responsible for. It's great when we can see both of those in a treatment plan, and that can really help break it down for a participant. This is what your responsibility is. This is what my responsibility is. We don't want to give the misconception that we are solely the ones in charge of finding them housing or finding them employment, because sometimes it can come across that way, right? I'm a housing specialist. I'm going to help you find housing. That might be misinterpreted as I am going to get you housing and you don't need to do anything. We don't want to convey that message. This helps really put some of the responsibility back to the participant. And again, like I was saying, help teach them what needs to be done in these steps in order to meet that goal, right? And when participants are really active in the process of obtaining their own housing, they're going to be much more invested in keeping it, right? If you do all the work for them, being an amazing housing specialist, they might not understand just how difficult it can be to find housing and might not be as invested in keeping it.
I think those are a lot of good examples, and trust Rutgers for coming up with good examples. Next slide, please. So this is the key questions for direct service staff. The kind of thing that I used to keep in mind when I had a caseload is to ask the person, what are we working on next time? To be very clear with myself and with them. Anessa mentioned too, are there things that they're going to do between times? So, and not to create dependence on us, but to teach the person to be more independent by saying, gosh, if you're going to go apply for a job and you don't have your social security card, we're going to need to get you a new one. That's something that a person could potentially work on their own or with your help. So maybe that's homework between sessions. And so the idea, the intent or interaction for the next visit, and potentially what's the homework in between time. What outcomes are we working towards? Should be in the service plan, treatment plan, program plan, rehab plan, whatever you call it. that treatment plan, and we'll show you, should also include who's doing what. So if the job seeker, the person seeking housing is going to do something and the staff's going to do something different, it should be delineated in that treatment plan, who's doing what and by what date, that kind of thing. How can I keep them engaged? We have a whole separate training on that one. And in fact, I think Darren and I are going to do our topical employment webinar on July 17th on engagement. So stay tuned, come to that. We'll talk about engagement. Am I bringing growth intent to my support? Or am I focused on compliance or that kind of thing? I'm going to do a little soapbox moment here again for folks that do housing specifically. I want you to take a minute to consider, are we promoting dependence on the system by providing housing subsidies without then sometimes the opportunity for a person to go to work so they can pay for their own apartment? Oh, hello, Kaya. My feeling is that if we're doing housing services and housing services are the end goal and there's nothing beyond that, we might be creating dependence. We might not. Some folks may not choose to work. Some folks, may have so many barriers to work that they've lost hope. There are a lot of things like that. But our growth intent is always to work our way out of a job, to teach a person to be so independent that they don't need us anymore. And so that growth intent should be a focus always. Next slide, please. Darren, you must still be here with us because you're advancing slides. Do you want to take this one?
Sure. So we've talked a lot about the necessity of, documentation, especially good documentation, and it is a major funding stream. I have yet to be in a service provider program where documentation wasn't a critical element of some of our productivity and revenue generating. And particularly this, scenario, the FCS, and the rates for supportive housing and supportive employment really, impact a program's ability to grow or even maintain or add staff to the program. So definitely some of the critical elements, of some of the documentation that we're talking with and, that individual service plan goals is like managing your time and documenting that time. That's all part of, productivity. Even with evidence-based practices for supportive employment, we look at different strategies of time management, how much time you're spending with the person, how much time you're spending out in the community, how much time you're spending with employers. All those things are critical aspects. And we look at this at community time, which can be individually you as an employment specialist going out and meeting with employers. That's what we call collateral time. If it ties back to the person's goals and that individualized service plan, that you can show that I am out doing this service on behalf of Darren because of his anxiety, because of his fear, whatever those barriers are, that you can go and get that information that could be really critical to how I shape my resume, those different strategies. So that can be an important piece, and collateral services can be part of employment services as well as supportive of housing. And it's a great way to maximize some of the services that we're providing, and also being able to have that opportunity to do some role modeling with folks. Don talked a lot about people being more independent. What a great way to make people more independent, integrate in their community, that we could show them how to engage with employers or demonstrate and show them, with landlords as well. And we've had some discussions of what happens with people when they stop coming to the office. Evidence-based practice says we do some engagement strategies. We're going to assert ourselves and be proactive and go out in the community and see if they're okay. Have that concern. Are you safe? Are you still interested in our services? I've noticed you haven't been to the office or missed a few appointments. Is there anything, other services that you might need to kind of get through a crisis that they're having? So really kind of connecting the dots and really having that person-centered focus for folks, because we really don't know why some of the disruptions occur unless we have that conversation with somebody. And for employment, and housing as well, is that development process for employers. How are we conducting job development? IPS has a lot of strategies that we can just focus on in terms of what we do, in terms of being specific about employers, the engagement. Are we just going out there to kind of check off a box? Are we actually really talking to the hiring manager to kind of find out what their needs are? What some of the positions opening, what skill sets do people look for? What do top candidates look like for certain employers? So we really want to, be intentional in our job development services and not just say, oh, they're hiring and come that back, but what's their hiring process? Do they do background checks? You know, for certain positions, maybe they do background checks. What do different employers do to really, recruit folks for their organization and learn about that process, or learn about when episodes of hiring increase and decrease for different organizations?
So golden thread, you've heard the terminology. Obviously, it's a complex enough system, scenario, whatever you want to call it, principle that Rutgers does a 6-series webinar session on it, and we have a variety of those that are recorded and I can share with you. But the bottom line is, anytime you're billing Medicaid, you gotta deal with golden thread. You have to follow the golden thread principle. Medicaid pays for medical stuff. If we're going to ask them to pay for housing, assistance to get housing, assistance to get employment, there's got to be a medical piece that's related to that. So as an example, somebody with extreme anxiety disorder may be unable to talk to employers on their own. They may be too anxious to do that, or too anxious to do interviewing, or even filling out job applications sometimes is, well, not sometimes, it's always anxiety producing to some degree. And so if a person comes to you with an extreme anxiety disorder, and that's the reason why you're helping them, you need to document some of the reason that's the reason why you're helping them and how it relates. So Darren had talked about transportation only in conjunction with a service. When I would work with somebody who was very anxious about interviewing or talking to employers or whatever, and if I was giving them a ride there, essentially I was doing my session in the car, if you will, on the ride to the interview or to talk to the employer, we would talk about maybe deep breathing, or how have you found that you've been able to handle your anxiety in the past, and will that fit today? Or let's do a little bit of practicing of the interviewing so you feel more confident when you get there. I would need to document in my notes that because of anxiety, we did interviewing practice on the way to the interview in order to increase confidence and reduce anxiety. It's not just a nicety to put that kind of thing in the notes, it's mandatory. When we talked a little bit about keeping your behind out of the sling, this is one way to keep your behind out of the sling when you're talking Medicaid documentation or Medicaid billing documentation, is to make sure to weave in that medical necessity. If Uncle Bob could take them, then Uncle Bob should take them. Uncle Bob can't. The person needs more help than that. So what are you doing that's different? Be detailed about it. Not to the degree that your note is pages long, or I used to joke about writing a novelette and had to work real hard to move away from that. It needs to be succinct, but it needs to contain the information that you have to have. We all know if it wasn't documented, it didn't happen. It wasn't done. The only way to bill Medicaid is to have that progress note with times, with the information from the treatment plan, with location, with who did it, all those kinds of things have to be in the note. What counts as documentation? A variety of things. The treatment plan does, the progress notes do, the assessment counts as documentation. Sometimes an email. I mentioned the exceptions to the rule that an agency here in town found that they should have kept their emails about having submitted ETRs and that kind of thing. So documentation is essentially anything that supports what's going on with the person. One of the things that some agencies do and some don't, I always told the people that I supervised that your documentation needs to tell a story. So if you say, I'm going to meet with Dawn on July 10th, and I'm looking at progress notes and there's no note for July 10th, the storyline is broken. My expectation would be if there was a note that says, I'm going to meet with Dawn on July 10th, if Dawn canceled or no-showed on July 10th, there should be a note that says Dawn no-showed. If sometimes agencies will not do those kinds of things because they can't bill for them. You can't bill for 0 minutes. If somebody no-shows or cancels, unless you've had, when they cancel, a 15-minute phone call with them that discussed why and what's happening and what they're doing instead and yada, yada, you can bill for that time. But some things to maintain that storyline need to be a non-billing kind of a note. The agency I worked for called them informational notes. They were always really brief because you didn't have to do the billing piece or that kind of thing. But it might say something like Dawn no-showed, Dawn canceled, whatever. When you're talking about the IPS principle, the individual placement and support principle of assertive engagement, how are you going to prove you've been trying to reach out to a person if you don't do a non-billing note? How are you going to prove that you've been doing that assertive engagement unless you say, went and knocked on Dawn's door, nobody answered? That kind of thing. And so if your agency doesn't do non-billing notes, I'm going to encourage you to talk to somebody about it because it's a piece that's important and in some cases necessary to show that you're providing the service that you need to. I see there's various other folks that are hopping off. Sorry to hear that that's having to go. So Danielle says, are we able to bill for 15 minutes for housing? I was under the impression it could only be 30 minutes or more with housing, and Anessa says 15 is fine. Christina said,
I
yes,
was
ma'am.
about to type out a longer response, but I'll just speak it verbally since we're on it anyway.
Okay, all right.
Definitely recommended to not have an overabundance of 15-minute interactions. That should definitely not be like the majority of case notes that we see with somebody. It's recommended that most are like 45 minutes or more. And of course, we know sometimes there's going to be like a quick phone call, quick care coordination, quick touch base. So yes, 15 minutes is fine. And don't overutilize them and don't inflate even shorter conversations into 15 minutes for the sake of billing.
Thank you for that, Anessa. Absolutely valid point. Next slide, please.
I can take this one.
Well, and I was looking at another question from Anessa. When we go out there when we go out to their unit to connect with them for their appointment, they're not home. Should we bill their regular insurance, not FCS?
Great question. So obviously a missed appointment is not a billable service. An attempt to contact is not a billable service. There is a way to potentially make up that time with another collateral service. If, for example, you were supposed to, well, I don't know. This may or may not apply to somebody who's already housed, but say you are supposed to meet with somebody and they don't show up or they're not home or whatever. You can get back that billable time by then doing an in-car search for housing, as long as you can tie that back to a specific participant. And when I say in-car search, I mean like you're driving around in your car, you're looking for yard signs saying like rental available. You're looking for like billboards around town, like things like that, because there are sometimes units that are not posted online that you can find while searching in your car. So I'm sorry, that didn't really answer your question. That was kind of a no, that's not billable when they're not home and you try to meet with them. But you could get that billable time back by looking for housing for either for that participant or for somebody else, as long as you can tie it back to them. Does that make sense, or was that helpful?
Yeah, and I will say for employment, same kind of thing happens. You can make up some direct service time by going out and doing job development on behalf of a person. But what you have to do is actually talk to the employer. To be able to bill employment search, it can't be online search. It can't be, going through Indeed or whatever. It's got to actually be talking to employers. I love the fact, Christina, that you said if you were out sick for a period of time, if I won the lottery and I moved to the Bahamas, I don't want the person to have to tell their story over and over again. I suspect all of you have worked with people that have said, don't laugh at me winning the lottery and going to the Bahamas. It's my retirement plan. But I'm sure you've all ended up hearing people said, I just told, this person or that person this whole thing, and I don't want to have to tell my story again. Part of the documentation, part of the reason for documentation over and above billing, and certainly that's a good one, is the fact that sometimes people are re-traumatized by having to tell their story again. We don't want to do that to anybody. So as Christina says, document, 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 because we want to be able to stay on top of things without having to ask them over again to tell their story one more time. We just don't want to have to do that. I'm going to say, as a part of good customer service, I had a doctor, an allergist once upon a time, that I would come in the door and he would say, how's your daughter Alexine? Because we would talk about a variety of things in the appointments. I think he actually did whole person care. In my mind, that was over and above, but you know what? That kind of thing should actually be the norm. When you prove that you're trying to get to know the person, you're trying to remember their backstory, you're trying to remember things that are relevant to them, they feel more valued. And so that should be something that I think all of us do is remembering some of that story. We're not going to do it without the documentation. There's just too many people. I see Zena talks about long-term rental assistance program, similar model. So it does look very similar. It does look very similar to what we're doing here in the state of Washington. All right. So golden thread of FCS, this is another one of those slides that we borrowed from the Rutgers team and the golden thread training. I'm not going to read it to you. You'll have it available to you in order to read, but you can see why they call it golden thread. One thing links to the next thing, links ongoing, to kind of the end goal, which is services that tie back to the assessment. All right. Next slide, please, Darren.
Well, I think we have like 1 minute or two left, Dawn.
Yeah, I think we do too. We have 2 minutes left. So here's the deal. I know I've seen a couple of folks say thanks for the Q&A and thanks for answering questions. We do that because we feel like if you have the questions that you need to ask, this is a great venue to do that. And you need the information. If you ask the question, it's because you need the information. We didn't get through all the slides. Anyone who wants us to go through the remainder of slides with them or has additional questions related to documentation or that kind of thing, please feel free to set up an individual training with us, and we're happy to do those kinds of things with you. I see Alana says, can you provide an example of what a proper billable note would look like? One of the things that we're going to send to you is a documentation guide that was developed early on in FCS. It has some examples that you're referring to, Alana. It has examples of treatment plan, progress notes, those kinds of things. Once again, if it's not enough, reach out to us and we're happy to spend time with you to do that. Other questions in the minute we've got left? Thank you for being here today. I hope that I know we all hope that this was valuable for you, but if it's not enough, reach out. Also keep in mind that you've got the slides and the link in the chat. So please feel free to access those. You'll have the video sent out to you. And whatever we can do to help, we're happy to. Video will be sent out, some webinars in one email. And so, and I will mention too, there's multiple Anessas still. You might need to reach out to us to get the information because we don't necessarily have your email address. So feel free to do that. Thank you, everyone.